Men with advanced prostate cancer have been managed with hormone therapy since the 1940s. The only real significant advance to that has been the addition of radiotherapy for non-metastatic disease, which reduces the death rates by about a half. But apart from that, the treatment's been pretty much set for 70 or so years. Around about 10 years ago, agents started to emerge which were either disease-modifying like zolendronic acid or survival-prolonging like docetaxel. So we set out to examine whether using agents like these at the time of diagnosis instead of at relapse would give you a bigger absolute gain in survival, which is what we were aiming to show. So the men going into the trial were either high-risk, locally advanced patients or newly diagnosed metastatic patients. It was also possible to go in the trial if you'd had prior surgery or radiotherapy, as long as you hadn't had more than 12 months of hormone therapy and it had all been completed more than 12 months previously. But they only accounted for about 6% of the men in the trial. So the primary outcome for the trial was overall survival, and we've effectively got three separate trials that we reported today. So standard of care versus docetaxel versus zolendronic acid and versus the two combined. So for zolendronic acid, we saw a non-significant improvement in failure-free survival, which translated, not very surprisingly, into a non-significant improvement in overall survival. For docetaxel, on the other hand, we saw a big improvement in failure-free survival, about a 40% improvement. And this translated into a 25% improvement in overall survival across the whole trial population. So the trial population was split into 40% non-metastatic, 60% metastatic. And when we did the sub-analyses by metastatic status, what we saw with docetaxel was that for the M0s, again, there was the failure-free survival improvement, but immature data with respect to overall survival, just insufficient deaths. In fact, the survival was rather better than we projected when we set the trial up. For the metastatic subgroup, which is 60% of the trial, obviously has more events as well, the worst disease, we saw big improvement in overall survival. So the median went up by 22 months. It went from around 3 years to around 5 years, which is obviously a huge and highly clinically significant improvement. When we looked at the combination of the two, it essentially looked like the docetaxel data. So they were possibly slightly worse, but essentially because zolendronic acid on its own doesn't really do anything and the combination looked like docetaxel, our overall conclusions were, certainly for metastatic men, that chemotherapy should be the standard of care for newly diagnosed patients. For non-metastatic patients, the survival data are immature, but there's a big improvement in failure-free survival. So we think that should be discussed with men as well. So some will take the view, yeah, I'll take the improvement in failure-free survival, some will take the view, and some clinicians may well take the view that giving chemo without a survival benefit is probably unjustified, and we will be undertaking further follow-up to address that. We also have a planned meta-analysis with the other docetaxel-containing trials and the other zolendronic acid-containing trials, and we're hoping to present the first analysis from that at the major European meetings in the autumn. So the other thing I'd like to mention is that the trial has quite a novel design. So it's a multi-arm, multi-stage design. So we set out to simultaneously investigate multiple different agents, and we used interim analyses based on failure-free survival to assess whether the various agents were impacting failure-free survival. We made the assumption that if you didn't impact failure-free survival, you were unlikely to impact overall survival. And that's broadly been borne out because although the zolendronic acid arm did impact failure-free survival a bit, it was not that much, whereas docetaxel impacted failure-free survival a lot, and that translated into an overall survival benefit. We've used the flexibility of the trial now to add additional treatments. So we've got other arms running. We've got an abiraterone arm given at diagnosis, which has completed recruitment and will report results hopefully here in 2 years' time. We've got a trial looking at giving radiotherapy to the metastatic patients, giving radiotherapy to the prostate, the premise being that if you control the primary, you'll slow down the rate of growth of metastatic disease. And that's still recruiting. And we've got a third arm which we added last summer, which is looking at the combination of abiraterone and enzalutamide. For the currently running arms, we're going to add the option of giving docetaxel to the standard of care, so that will be across all of the arms as well. So the control arm is itself flexible and we can adapt it to changes in the standard of care. We were a little disappointed by the zolendronic acid results, and we've only analysed the primary outcome measure and the failure-free survival and toxicity data. What we've seen in another trial I've been involved in called Trapeze, where we looked at docetaxel with or without zolendronic acid, was that in that trial, again, we didn't impact the primary outcome measure, which was failure-free survival in that trial. But when we looked at the secondary outcome measures, we turned out to have had big impacts on bony morbidity, on symptomatic skeletal events. So we will be looking very hard at that. That's one of our secondary endpoints in STAMPEDE, and we haven't looked at that data yet. So there may yet still be benefits in zolendronic acid in pre-planned, pre-specified analyses which we haven't carried out yet. But on the primary outcome, it's negative, which is disappointing. For the docetaxel arm, we're clearly delighted by the results, and obviously it's what we hoped we'd see when we set the trial up. So I think for metastatic disease, I think particularly as there are other studies, there's two other studies, a French study, JETUG 15, and the Charted study presented in the ASCO plenary last year. They all point in the same direction in that they all improve failure-free survival. Although the JETUG trial didn't improve overall survival, it trended that way. If you put all three studies together, they're very consistent with a survival benefit for upfront docetaxel in newly diagnosed metastatic disease. So we think that should be the standard of care for men who are fit enough to receive docetaxel, which obviously is not everybody. For non-metastatic disease, again, there's a very consistent improvement over a number of trials in failure-free survival. That may be enough to justify for some patients using in that setting as well. I think it's certainly something that I'll be discussing with patients. I think probably for most patients it's probably premature to say it's the standard of care to give docetaxel up front. But we hope with the meta-analysis, which we're in the process of doing, we'll be able to get a more definitive answer with respect to the impact of these treatments on survival. I think if it improves survival, then I think then the standard of care will shift further across the spectrum towards docetaxel.